Welcome to lecture for crisis intervention. We'll be talking about some basic crisis intervention skills. This lecture is going to focus, like I said, on basic skills, many of which are relevant for therapeutic interventions not involving crises. But to help us to think about using these skills in the context of crisis, we'll talk about Gilliland and James's 6-step model. So you see there's kind of overarching assessment in the model. So throughout the model, you should be assessing the client, gathering information. And then while doing that, you also need to define the problem, ensure client safety, provide support, which is the first is kind of those three together are the first half of the model, where you're kind of listening and supporting and making sure the client's okay, and then and also gathering information, doing assessment. And once you've got an idea of what's going on, then you move to the action part, which involves examining alternatives, making plans, and then getting a commitment to enact those plans. Okay. So we'll come back to the model in a bit, but first we're going to talk about some basic skills that we'd use throughout this model. So a diverse skill set's needed to act effectively both in assessment, which occurs throughout the model, and then in each of the 6 steps. Before we talk about what needs to be assessed, or what's done in each step, we'll discuss the foundational listening and action skills, starting with core listening skills. So what does listening do for us in crisis intervention? Well, 2 things. 1, it helps us to gather information, which is the assessment piece, and 2, it contributes to a therapeutic environment. And by therapeutic, I mean growth promoting. However you want to think about the word therapeutic. If you think of healing or growth promoting, whatever, but it helps make people better, right? Is a simple way to say it. It can do these things when certain conditions are met, and we'll use Carl Rogers' terms to identify these essential conditions which are related to skills when listening. Because then again, listening isn't just about sitting there quietly. It's a lot more than that, and a lot harder than that. Empathy, one of the core skills, right, which is an attitude as much as a skill. Trying to actively convey that I want to understand you right here, right now, as a person. Okay. And to do that, obviously, you have to attend to the client, which has a lot to do with nonverbal stuff, right? Your posture, your facial expression, level of eye contact, right? And in general, you want to be present and focused, but not too intense, right? And in the appropriate level of eye contact and the appropriate posture and distance to the client will depend on the client and their anxiety level, and their also kind of cultural backgrounds in terms of their preferred interpersonal space. And if as you increase or decrease your distance from the client, you should get a feel if you're being sensitive to their nonverbal behaviors, get a feel for what's comfortable for them. But even if you're slightly wrong, as long as it's clear that you're trying, that's really what matters here. So you want to be attending, focused on the client. You're not thinking about your grocery list or when you got to pick up the kids at school. Everything right now is about this client in this moment, and you're doing everything in your power to communicate that's where your focus is. Empathy also involves largely the reflecting of feelings. And James talks about saying, I understand that you blah blah blah, which okay. Personally, I shy away from that phrase because often people will use it without elaborating, which I think it's okay if you say, I understand that you are feeling da da da, and then you identify it. But too often people just stop with I understand, and for some clients that may work. For a lot of clients, inside their head, they're going to be going, no, you don't understand. How can you understand? They may even tell you, no, you don't understand. How could you possibly understand? Right? So rather than trying to tell them you understand, show them that you understand, or at least that you're trying to understand. And you do that by attempting to reflect feelings, using your tentative language to say, okay, well, it seems like you're feeling this. It seems like you're really sad. It seems like you're really anxious. Whatever, think about all those emotion words and try to put it together and put it in context with what they're talking about. Right? And in general, when we talk about reflecting what the client's saying, it's a lot easier to reflect content than affect, but the latter, reflecting affect, is more important. So an example of something a client might say, sometimes I want to just crawl into a dark place and hide from reality. And other times I want to give up completely. I'm living on other people's hopes and their faith that life will get better. I keep going, but I wonder if it's worth it sometimes. What's an empathic response to that? Okay. I'll say it one more time, and again, be thinking, okay, what would I say to a client that's telling me this? Sometimes I want to crawl into a dark place and hide from reality. Other times I just want to give up completely. I'm living on other people's hopes and their faith that life will get better. I keep going, but I wonder if it's worth it sometimes. So, what are the feelings under that? Right? And it'd be easy to say, "Oh, you're feeling hopeless." More than that, what are the deeper feelings? So try to think about that, and what would you say? What's the core affect there? Okay. The other thing to think about when reflecting feelings is to be on the lookout for discrepancies between content and affect. If they're saying something about being really sad, but they don't seem sad, note that, and you might need to point that out. They might be denying some feelings and not allowing themselves to feel some things. Which, with crisis situations, you got to be careful, because that may be their coping mechanism, and there may be just this well of sadness that they're keeping the lid on, and if they open it, they'll feel overwhelmed. And again, in therapy, generally, we want people to feel safe enough to explore their feelings and realize that they won't be overwhelmed and destroyed by their emotions. But in crisis, if you've got to do some work in terms of making some decisions, you've got to use your clinical skill and acumen to gauge, okay, how likely it is that this client, won't be able to think clearly for the next hour. And in this hour, we've got to decide what they're going to do next, and decide what the right thing to do is. Should I uncover and let them feel, or is this what's working for them right now, and they're able to function without tapping into that emotion? Right? Now, if ignoring that emotion keeps them from moving forward, then yeah, you may have to pull back the cover and get into some of that the messier feelings. Right? So reflect feeling, and then also restating and summarizing what the client is saying, especially if the client kind of goes off on this long tangent. Communicating that you're trying to understand them. One way to do that is to give those brief little summaries about, okay, so what I'm hearing is this, this, and this. And you keep it as brief as possible, but it's helpful for often you and the client, right? Especially if they've covered a lot of ground, to kind of organize the information and put it in perspective. Right? Best to do it as briefly and succinctly as possible. You don't want to go on your own little soliloquy, just reiterating exactly what they said. But if you can summarize it briefly, then it kind of helps the client go, yeah, okay, there's that, and they can go off on whatever else they need to talk about. Okay. So you want to communicate empathy, that you're trying to understand. Again, and you don't have to be naturally empathic to be a good counselor. Some people are. Some people just can tell what another person is thinking and feeling, and that's good for them. You don't have to do that. It's not a prerequisite. You have to be willing to try and to communicate that you're trying, and that's what matters more than getting inside somebody else's head. Okay. Related to that, genuineness, being your true self. And genuineness is important for a couple of reasons. One, you want to be modeling genuineness in the hopes that the client will reciprocate, because you're going to help them a lot better if they're being their real selves rather than putting on some facade for you. And also, if you're genuine, it helps promote a sense of safety for the client. That you're not just some drone doing a job who's maybe evaluating them and wondering if they're crazy. You're a person in the room with them, and that is comforting. Okay? And to be genuine, it's about one thing. It's about being congruent, right? Congruent in your actions and in what you say and in what you're feeling, right? So if a client says something and they say, "Oh, does that does that disgust you? And you say, no, not at all. But you recoiled when they said it. That's not genuine. Now, if you genuinely have a reaction of disgust to something a client says, and you may, then you have to own that, right? Because they're going to know. And if you say no, they're going to know, okay, now I can't trust this person, and in whatever they say, I've got to take with the idea that they might be lying to me. Oh, you care about me? Sure, whatever. So you have to own your feelings and use those I statements, but doing it in a therapeutic way. When you talk about some of the choices you've made about hitting your child, there's a part of me that reacts to that, and I feel bad for the child. But I also know that you're doing the best you can, and that's not what you want to be, what you want to do, right? So you have to be genuine while also being accepting, which we'll get to in a minute. And that's really tricky with some clients. It's hard to be genuine and accepting, but it's possible if you can again kind of separate the behavior from the person. Right? That behavior really is not good. That's not. I can't sanction that, but you are a person, and your value isn't determined by what you do. We'll come back to acceptance in a bit. But so being congruent, owning your own feelings, being spontaneous, right? Again, not being a robot or a drone trying to follow some manual, trying to follow this model. Okay, now what step am I on? You have to be present with the client and be confident enough in your own abilities to go with what's there in front of you, and to trust your instincts. Because as much as we like to talk about the science of psychotherapy and of crisis intervention, a lot of it is still art. A lot of it, we can't define what makes the right step in therapy versus the wrong step. And there's something that comes down to your gut feeling or instinct, and you've got to be willing to trust that. Being genuine also allows for self-disclosure and therapeutic self-disclosure. And you have to be careful here to use self-disclosure appropriately. Right? I'd say be very careful about self-disclosing your experiences. Right? Especially if a client is experiencing some traumatic, has experienced a traumatic event, and you maybe have experienced something similar. That's dangerous waters. Right? The client might identify with you, but they might also think that you're assuming your experiences are the same as theirs, and they don't feel they are the same. Well, mine was nothing like that. No, oh yeah, you lost a child, but your child was 17. My child was 4. It's totally different. Right? So if you are going to talk about having similar experiences, think about why you're doing it. Are you doing it for yourself because it's bringing up memories for you and you need to talk about it? If so, not appropriate. If it's because you have a clear therapeutic rationale, so I think this will help the client in terms of building rapport, in terms of normalizing their experience, in terms of them trusting me when I'm talking about other resources that may be helpful because they've been helpful for me, then do it. But think about your reason, and then also I would say preface any kind of experience with some kind of disclaimer about well, it's not exactly what you're going through. Or my experiences, your experiences are your own, and mine are my own. But there's some overlap. I lost a parent recently, or I was in a car accident where I was immobilized for 6 months. Whatever it is, but preface it with some sort of disclaimer that it's not exactly what you're feeling. I can't fully appreciate exactly how you're feeling right now, but I have had some experiences that are similar. I think you can do that. I think self-disclosure in general is more helpful when you're self-disclosing feelings, especially complicated feelings, because again, it's good modeling for the client that it's not that, because usually they're feeling a lot of complex emotions in a crisis, right? And if they can see that you have complex emotions too, and it's not crazy, it's normal to have sometimes conflicting emotions, that can be therapeutic, right? So, maybe if a client's talking about a sexual assault, as you talk about the attack, I can feel my body tightening up with anxiety and fear, and I can see you tensing as well when you talk about it. It must have been terrifying to think about what was happening to you in that moment. I just get it. So you can tell them, okay, yeah, because they're going to notice you tensing up, so you want to own that, and you can talk about it. Wow, and you're using it to again try to convey empathy. I'm feeling just a little piece of it just hearing you talk about it. It must have been really hard for you. It must have been a burden, and then you can take that wherever you need to take it from there, depending on where you're at in the session. Okay, so empathy, genuineness, and then I've already alluded to acceptance. Which we also talk about. Another term would be unconditional positive regard. Again, it's not that everything that the person do is wonderful and acceptable, but that they have intrinsic value that cannot be diminished. Right? They're a living, breathing human who's doing the best they can with what they've got, right? And you accept them for that, not for what they've done. Okay. Communicating acceptance often involves kind of telling them, normalizing experiences, responses for them. You can talk about typical experiences. It's not uncommon to have these mixed emotions like this, to feel this way and then feel guilty about feeling this way. And you can help people feel less alone, and that this is a way people feel often. It's okay. I accept your feelings. They're not invalid. So you can do a lot of kind of verbal normalizing and communicating of acceptance. But then a lot of it is kind of going back to, like, similar with empathy, a lot of nonverbal communication, right? So whenever they're talking about things that are really emotionally sensitive, conveying with your posture, and especially your face, because your face, you can't hide your emotions with your face, so you really have to feel it, feel acceptance. Because they're talking about feelings that are unacceptable to them. They're talking about maybe we've lost our house and we have no money, and my dad's really sick, and oh my gosh, sometimes I just think I wish he would just go ahead and pass on. That way, we could get the insurance money and we could get the house back. And they may feel incredibly guilty about that. And if you judge them in that moment, they will see it. So you have to really kind of go in there knowing that, and truly feeling that you're not going to judge somebody for their feelings. And it's important here to distinguish what type of judgment we're talking about. I'm not talking about judgment in terms of discernment, kind of right and wrong, but judgment in terms of condemnation. You're not going to condemn them. And you may have an opinion about whether or not it's appropriate to do one thing or do another. But regardless of that, you're not going to condemn them for their feelings. And if you can kind of internalize that sense of acceptance, then it's easier for it to come out in your nonverbals. But you really have to go in there with that attitude, and then work to communicate that. Okay, so those nonverbal communications, and then using silence, which James talks about using silence as a way of communicating empathy, which I think so. But I think even more so, it can be used to communicate acceptance. When a client is experiencing a lot of emotions or crying, if we can't accept those feelings, we'll talk over them. And we'll say, it's okay, don't cry, here's a tissue. Right? And you may think, well, no, I'm being empathetic there. You feel bad about crying, and you don't want to cry, and I don't want you to cry. Oh, I don't want you to cry, right? So now I'm not being accepting. So letting somebody be upset and sitting there in the silence, and it's not this kind of cold clinical silence where you're sitting back with a clipboard looking at them, watching them cry, and going, that's interesting. You're still leaning forward, you're in the moment, you're present, you're looking at them, you're not staring at them, but you're communicating. You're sad, it's okay, I can handle it. I'm not going to be overwhelmed by your emotions. And if I'm not going to be overwhelmed, you're not going to be overwhelmed. It's safe to feel sad. It's safe to feel angry, right? And I can accept that. And one of the most powerful ways to communicate that is silence. Again, if you're using the appropriate nonverbal communications concurrently. Right. So again, your feelings are not an imposition, and you don't have to hide or distort how you're feeling to make me happy or keep me from running away. I'm going to be here regardless with you. And also, silence, of course, gives both the client and you a chance to process. Right? So you're not just jumping from one thing to the next because you feel like you have to keep talking. Right? Okay, so with these core skills and attitudes as a foundation, you can begin to add other strategies to your armament of skills. Let me talk about kind of facilitative skills. So beyond kind of the creating this environment, we can use some other listening skills to help a client move forward. Right? And obviously, asking questions is important. And we might, at some points, ask more open-ended questions. And these are helpful, especially in building rapport and preserving the client's autonomy. Right? If we ask just closed-ended questions, then we're in the driver's seat. We're directing the entire session, and they have reduced autonomy. Which, depending on their level of functioning, we may have to do that. But as much as we can preserve their autonomy, that's usually our goal in any kind of therapeutic intervention. But open-ended questions are great for getting clients to, share information, but also getting clients to process and think about stuff. Right? For a closing question, it doesn't take them long to generate a yes or no answer usually. But open-ended, they've got to think about it more. And sometimes the thinking about it, the processing, is what's therapeutic. Right? And they'll come up with ideas and solutions and resources that it would have taken you 3 days to identify using closed-ended questions. But one open-ended question, 20 seconds of silence, and there's this great new idea. Okay. Closed-ended questions are also sometimes helpful. Right? So I won't say you can only use open-ended questions, especially in crisis intervention. Especially when you initially need to identify information quickly to discern a course of action. Right? Do I need to call the cops? Is this person gonna kill themselves here in my office? I may have to ask some closing questions right now and be very directive. Right? So they certainly do have a place. And closing questions can also sometimes provide structure that's comforting to anxious clients. So clients that are generally anxious and not sure about what they're supposed to be doing, right, and looking to you really for guidance, they may need some closed-ended questions to get them warmed up and feeling safe enough to talk more. Another strategy involves creating awareness, and this is usually whenever you're restating or summarizing. We talked about before what a client has said, and you add a little something to it. You add some comment or question designed to provoke thought on the client's part. It's kind of those. Well, I wonder. You said this, and this, and I wonder if da da da. Right. So sometimes what you're doing, you're trying to bring to conscious awareness warded off, denied, shunted, or repressed feelings, thoughts, and behaviors. Right? That because the client is using energy to repress them, is a kind of psychodynamic understanding. The client's using energy to repress and not feel, not think about this. They don't have energy to problem solve in the crisis situation. So we've got to free up the energy by creating some awareness of what they're holding back and what they're not thinking about. I wonder, if you're feeling guilty about feeling this way. They may go, oh my gosh, I am. I hadn't really thought about it. And then they can, there's kind of, yeah, I am, and it feels so horrible, and then they can move forward, and now we can start going again and can get them unstuck. Okay. So creating awareness, which is kind of a psychodynamic thing, allowing catharsis, which catharsis is obviously a very psychodynamic term as well. But this is about sometimes the client needs to vent. And they need to vent to take enough of that emotional pressure off so they can think rationally and do some of the planning stuff you need to do in the later stages of the model. And catharsis, especially the way that the original kind of psychoanalytic people talked about it. They thought about it being kind of a sufficient therapeutic event, and we know from a wide variety of research that it's generally not. Catharsis is not sufficient in and of itself. Just venting makes people feel better in the short term, but it doesn't fix things. Right? They used to think it did. It doesn't. But it may take off enough of that emotional pressure. I need to talk about that now. Now we can talk about what needs to be done. A side note here, you also need to know when to rein a client in if their kind of venting is getting dangerous. If they're escalating and becoming more agitated, showing psychomotor agitation, and there's more heat, more anger, hostility to their venting, you've got to watch it. You don't want them to get too far up to where then they're going to become violent. Right? It can be tough sometimes to know whenever you feel the urge to rein somebody in. Is it because I really think there could be danger to themselves or to me, or is it just because it's uncomfortable hearing people be upset? And you've got to, again, use your kind of clinical acumen to make that distinction. And then if you say, okay, it's getting dangerous, that's when you have to become more directive and say, okay, I can see you're feeling really upset right now. And you've talked about this, and this. And those things, when you think about this, it makes sense to feel really angry. Right now, I need you to breathe slowly. So you're going to kind of exert some control over the client. You're going to take away some of their autonomy for a minute and be pretty directive to get them to calm back down to a place that's safe. And again, not because it's not okay to feel bad, but because whenever you get really angry, it at some point, it stops being helpful and cathartic, and it becomes destructive. Another technique strategy would be increasing expansion and emphasizing focus, which is kind of some CBT type stuff. So again, when restating or summarizing, you add some comments, right? And you're either going to be providing a reframe that better helps them see the big picture when they seem stuck, so it's increasing expansion. So they're thinking, well, there's no cure, none. There's nothing I can do, right? So, well, you're right that a cure has not been identified. But there's much that you can do or choose not to do. How pleasant or painful your life will be is related to the choices you can still make. So again, kind of getting the client, they're focused on one aspect of the crisis, maybe that they're terminal. You want them to open up to, yes, that point, no arguing there, but there are other things to think about. Open your focus to what else you need to be concentrating on to have, a life and not just waiting for death. So increased expansion, or some clients might need that emphasizing focus. They might be so lost in the whirlwind of all their thoughts and feelings that you need to provide focus, right? So there's a lot going on right now, but what's one thing you can exert control over right now? Right? So again, they're worried about this, and this. Okay, let's talk about one thing, and just because they're not going to get anywhere chasing their own tail. And so you may have to, again, be a little more directive and get them to focus on one thing. Last thing with this, implementing order, which is often done when summarizing, obviously, what the client has said. And you can do a couple things. You can identify different areas of concern. Okay, so I hear what you're saying, and you're talking about you're worried about losing the house. There's concern about your kids, and there's concern about this. Right? So you're going to kind of, and maybe they talked about 10 different things related to the house, 10 different things related to the kids, and you're kind of pushing these things together into groups so that they're more manageable cognitively for them and for you. And then you also may kind of reflect what seems to be the client's priorities. And what it seems like you're most concerned about and what's most important for you right now to problem solve on is where the kid's going to be, and so you're helping organize the chaos, implementing some order in their chaotic thoughts and feelings. Right? And again, you don't want to necessarily use all of these strategies. You might use some, you might use none. It varies across therapists and also varies across clients. Right? Some will be more appropriate for some clients, and some will be more appropriate for others. Okay, so these listening skills we've talked about are intertwined with the action skills that we'll now address. And the application of these action skills will look different depending on how active or involved a role you need to play. Right? And this depends on the client's level of mobility. So how autonomous and how much action they're able to take, or if they're on the other end where they're not able to do much and they're really impaired. They have impaired functioning. Right? Which you'll have an idea of that if you've done the appropriate therapeutic assessment, which we'll talk about again in a minute. But again, in terms of your role, it might be non-directive toward that end of the spectrum, right? And this is, for many of us, ideally when the client has a high degree of mobility, right? They're upset, but they aren't stuck. In these instances, you can mainly use your active listening skills. Right? The client's probably able to come up with a plan or solution if given a safe environment to explore options, maybe vent some feelings, and if asked, a few questions to point them in the right direction. So asking them, well, what do you think you should do first? Okay, which of the things you've talked about seems like the best option? Right? So again, it's not just they come in and they tell you what they're going to do, because then it's not intervention. It's just I don't know what you would call that. So you are guiding some. It's not completely passive, but you're not determining you're being less active in determining the direction. You still are directing some, right? You're deciding what questions to ask, but they're more open-ended questions, and it's giving the client more latitude, just kind of provoking. Okay, did you think about this? Okay, have you thought about this? And now what are you going to do? Okay, sounds great. But you might have some clients that aren't quite there with regard to autonomous functioning, but they still have some psychological resources at his or her disposal. For these folks, you might use a more collaborative approach, right? A partnership. It's where we are going to figure this out together. Right? So it's not, again, I'm not telling you what to do, but I am providing more guidance in identifying what choices need to be made, what options exist for those choices. So it's we need to figure out what to do first, rather than telling me what should you do first. We need to figure out together. Let's talk about what some of our options are. And here, you and the client will both be generating options. Whereas in a non-directive approach, the client is capable probably of generating options on their own with very little input from the therapist. The therapist won't say, and you also might do this. The therapist might comment on options, but they probably won't be offering them. Right? So just more directive here. So for collaborative, we'll be saying, okay, and have you thought about this? Have you thought about this? But also, you got to do some too, because we're a team, we're a partnership working together to figure out what to do. And then at the other anchor, so non-directive being one anchor, collaborative in the middle, and then the other anchor being a more directive role for those clients who need really a firmer hand to support them, those who have more severe functioning. So here the therapist assumes a great deal of responsibility for coming up with ideas and deciding on a plan. Right? And you still want to preserve as much of the client's autonomy as possible. Right? So if you can, sometimes you may just have to say, this is what you need to do. But if you can, present them with, two choices. I need to take 2 steps today to keep yourself safe. There are 2 things you can do. You can call your mother to let her know you'll be coming to stay with her tonight, or you can call the number for the shelter to find out about staying there tonight. Which one of these 2 are you going to do? So again, this person can't generate options of their own, but still, I want them to make some choice, have some choices if they can. They might not be able to, and if they're not, then you're probably looking more at somebody who's going to need hospitalization or other inpatient care. Because if they don't need to be hospitalized, generally they're still able to make choices. And once they can't make choices, then our red flags are going off in terms of danger of self-harm and harm to others. Okay, so you'll have a different role depending on the client, and your role may change with one client. Right, so you may have to be really directive at the beginning, and then as you are using your listening skills and they're venting, they might be pulling it together within a session. Or if you're somebody you're seeing, for a couple of days. Remember, crisis intervention is usually short term, but you're seeing them a couple of times. From session to session, they may get more mobile. Hopefully, they will, and you can become less directive. Might go the other way too. You might start off non-directive, and you think, okay, I think they can handle it, and then something else happens. Some life event makes things worse, and now it's decreased their psychological resources. They become more immobile, and now you have to move into a more directive role. So again, it isn't okay with this client. I have to be this way. This is flexible. You have to be able to move on that continuum where you need to be in response to what the client needs. Okay. But whenever you're acting, so the stuff you do with the client, it may involve providing guidance, right? Which often involves giving them usable referral information. Right? And James has a nice discussion of several things to keep in mind related to referrals. And I won't reiterate all that, but make sure and look at that. And just also remember that what this looks like will depend greatly on how directive you need to be with the client. If you're pretty non-directive, you'll have them talk about resources. What resources are you aware of? Which of those sounds good? Da da da. On the directive end, you may have to tell them this resource, and you may have to tell them you called during this time, or you're going to call right now in the office with me, right? Because I don't think that you have the ability to make the call on your own. Right? So I'm going to, again, assume more responsibility. We're going to have this brief period of dependency, right? Which again, we usually don't want dependency. Sometimes it's necessary, especially in crisis intervention, to create a temporary dependency if they're not able to function on their own. So you're going to call in my office right now and find out if they can help you get your water cut back on, or whatever it is. But again, depends on what role you need to take. Providing protection, obviously always important. You always need to be ready to take steps to keep the client safe, and this may mean involuntary hospitalization, which usually involves calling the police to help escort the person to the hospital. And we'll talk more about this when we have a whole chapter on lethality. So just kind of be brief here. It may mean writing to them with the hospital. It may mean connecting them with law enforcement to keep them safe from somebody else. Right? And in general, you're obligated to keep the client safe. It's our primary ethical obligation. But our other ethical obligations aren't out the window whenever there's a safety concern. Right? So if you're concerned about the romantic partner possibly harming them, and so you break confidentiality and call the cops on the partner, that may not be ethically or legally justifiable. Depends on the level of harm, if it's imminent harm, all that stuff. So it's not as, okay, well, I have to keep them safe, so nothing else matters. Confidentiality still matters. It matters a great deal. And you have to be able to balance those things. Safety is of utmost importance, but it doesn't make anything else, it doesn't make all the other stuff not important. Okay? So we want to, again, keep the client safe while maintaining their confidentiality as much as possible, having them maintain their autonomy as much as possible, and we want to be as beneficent and non-maleficent, so do as much good and as little harm as possible. Okay. Providing protection, building on existing coping skills. So asking a client what's worked in the past in other situations, and again, this is about whenever you're helping a client identify steps and do things, you may be teaching them some new skills. But again, for crisis intervention, this isn't long-term therapy. They don't have a lot of time to learn a lot of new skills. So if they've used something else in the past, even if it's not the best skill, maybe there's a better skill, but they've used something and it worked, okay, we're going to go with that for now because we know it's worked. And we know it's worked for you. So again, very individualized approach to crisis intervention. And then, of course, you want to attend to the client's immediate needs. And this means that in terms of the actions you take, you may need to do more kind of social work stuff. You may have to help them find shelter and clothing before you do any counseling. Right? So you have to, again, think about your role being a bit more broad with crisis intervention than with your typical psychotherapy. Okay, so we've talked about some of the basic skills, listening skills, action skills, and now let's kind of get back to the model. And before we can begin with the 6 steps, we start with some assessment, right? Because again, assessment is this ongoing process in crisis intervention, right? But more effective helping occurs when it's grounded in information about the client you're working with. Because again, like what you said, although crises are universal and that everyone experiences them, the experiences of crisis tend to be highly individualized. So everybody experiences them, but any person's experience of crisis is specific to them. So you need to find out about this person. You need to find out who and what you're working with before you get too far down the wrong road in terms of interventions. Okay. So the assessment occurs throughout the model, but it's also kind of a precursor to the model. Before we start even identifying the problem, there's some things we need to know. First and foremost, lethality, right? Risk of harm to self and others. Again, like I said, we'll talk more about this in the future and exactly what you would look for and how you do that assessment, but know that that's your initial thing. Okay, before I start talking about letting you vent and whatnot, I need to find out if this person is going to hurt themselves. Right? I've got to get some idea of the client's level of functioning in terms of their equilibrium and mobility. Right. So are they kind of generally in balance right now, and it's just kind of a rough patch, or are they really out of balance and off kilter, and this is a significant crisis for them? And then also level of mobility. Are they able to take actions, or are they immobilized to where they become paralyzed by the crisis? They just don't know what to do. Right? So I'll be looking at their affective, behavioral, and cognitive functioning, which we'll look closer at client functioning in particular in just a minute. I also want to identify if there are kind of complicating psychobiological factors present. Right? There are certain things that may render a person atypical with regard to their neurological functioning. Right? And it may complicate my intervention. So I might think, okay, well, this person's brain really works differently, probably, than other people's, at least, or it is right now. Right? And so some of the things I might assume about what would work and what to do, I might have to think a little differently. So I want to assess for prior trauma, psychopathology. If somebody has schizophrenia and they're in crisis, your approach is going to be different than if they didn't have schizophrenia, right? And their use, misuse, or abuse of drugs, legal or illegal, right? If they're high or on withdrawal or suffering from addiction, there's some things that are a little more complicated about that. Okay, so again, your approach may be different if a person has any of these things. If they have a previous history of psychotic episodes or manic episodes. So if I know this person's bipolar, I've got to figure out, is this person manic right now? And that's their kind of affective state means something different, right? If I know they have a history of mania than if they don't, right? Because it's somewhat more normal for somebody with bipolar disorder to be manic than somebody who doesn't have bipolar disorder to be acting like they're manic. If they don't really have bipolar disorder, then those same kind of behaviors indicate something different. Right? And then I also want to get a general idea of their ecological context, right? So information about where the person is in life. Some factors to be considered are the client's age, educational level, family situation, marital status, vocation, financial stability and obligations, legal history. Are they on probation? Right? Their religious or spiritual orientation, physical health, past history of dealing with crisis. And whenever trying to figure out this stuff, which hopefully a lot of it you can get from referral information before you actually sit down with the person, if it's in that kind of setting. But again, trying to find out as much about them as possible, and you want to be keeping an eye out when looking at all this stuff for potential sources of support for the person. Okay. And again, and this is something where you'll be using your listening skills that we talked about to gather this information. But the initial, I think of this being kind of an assessment burst, right? And again, you're going to be assessing throughout, but there's an initial assessment burst where you're quickly trying to get a picture of what's this person like, this kind of psychosocial biological snapshot. Okay, I need to get enough information to not make really bad decisions. So I may not know enough to know exactly what to do, but I want to identify if there are any pitfalls and things I need to look out for. So I have this assessment burst, and it may look a little different than the listening skills we've talked about, right? It may be more closed-ended questions, probably less use of silence, because you may need to get information fairly rapidly to know your next step. Do I need to call the cops to help me right now. But keep in mind, because this initial burst is a little different, your conclusions are based on a small sample of client data, and those conclusions should be open to continual revision as you keep assessing throughout the intervention. So I get an idea of, okay, what this person is like, because I need some idea, but I know that it's probably not 100% accurate, and I'm open to correcting that image I have of what's going on with this person. And also the fact that what's going on should change, especially in terms of client functioning. It should get better. It might get worse, and I need to know if it does. Right? And that's, again, why assessment occurs throughout the process. Okay. So in terms of assessing client functioning, the authors, James, came up with, I think, a unique tool for organizing the gathering of these data, the triage assessment system, right, which looks at individual functioning in 3 domains: affective, cognitive, and behavioral. So when looking at the affective domain, you identify, obviously, the primary emotions. If it's more anger and hostility, anxiety and fear, sadness and melancholy. Right. And you identify which of those is the primary affect, if there's more than one. So again, just kind of get an idea of, okay, what's this person feeling right now? And then you also assess the severity of their affective impairment, when I think of it. And you want to be thinking about the amount of time experiencing negative emotions. Again, we typically don't talk about positive emotions in crisis, and we don't worry too much about assessing those. Obviously, you want to pay attention to those in the back of your head, but in terms of assessing how well the client's functioning, we tend to focus on the negative. It's a bias in our field. But amount of time they spend experiencing negative emotions, the intensity of those emotions, and is the amount of time and the intensity proportionate to the situation, which can be really tricky, especially because you've got to keep in mind, again, cultural context. Because how upset and for how long a person has been, what's appropriate, what's typical, differs across cultural context. And you've got to be sensitive to that, right? If you want to help somebody and not overly pathologize or under-pathologize that person. And then also, are the emotions felt to be generally under their control? So I'm feeling upset now, but I kind of know it will get better, or I know I can do some things. I can put it back in if I need to, if I have to go to work, I have to go pick up my kids, or is it, they're really being immobilized by these feelings and they can't control it. It's this uncontrollable anger, uncontrollable sadness. Related to this idea of emotional severity is the idea that James talks about of having an emotional reservoir, right, which is basically you have an ability to cope with negative emotions, and that ability feeds on this kind of, I think about this construct of a reservoir, this tank of emotional fuel. And if the tank gets close to empty, then as things continue to cause emotional turmoil, you have less fuel to deal with that. Now our concerns about harm become more prominent, because if we're less able to cope with negative emotions, but the negative emotions aren't going to stop coming, then we'll probably start using more maladaptive coping mechanisms, or possibly looking for ways to escape feeling. Especially if feeling bad, you don't want to feel that way if you can't deal with it. How do you get away from negative feelings? Well, you can get stoned, you can get high, or you can kill yourself. Right? And neither one of those are generally good choices for our clients. Okay. So we want to assess the primary emotions, assess the severity, and you can assign a number score to that, and use with the triage assessment form. And then you also, not on this form, but nothing you want to kind of be looking at and thinking about, is the duration of their affective distress. Is it something that's more acute or chronic? Right. So is it something that's reflective of an ongoing pattern, chronic? Or was their previous functioning generally healthy and adaptive? Right? So what you do right away might not be that different in terms of crisis intervention right now. But in terms of the plans you're making with them, may be different. Right? If this is somebody who's, part of their affective distress is consistent with an ongoing pattern, we're going to deal with the crisis, but I'm also going to refer you to long-term therapy. Right? If not, then I may talk about the possibility of long-term therapy, but I'm probably not going to push it as hard. Right? If I think that you're going to resolve this crisis, then you're probably going to be fine. So, in that sense, it's important to pay attention to that. Okay. We already talked about the emotional reservoir, the behavioral domain. So you're wanting to look at their reaction to the problem, and is it typified primarily by approach, avoidance, or immobility? And so there's some precipitating event, some problem that's causing difficulties, and are they trying to do stuff? And it could be that they have this kind of approach reaction, and it's fairly adaptive. They just need a little more help. Or it could be that it's a maladaptive approach response. They found out that their kid is diagnosed with an illness, and they spend 12 hours a day, every day online on WebMD and Medline looking up stuff. But that's all they do. They don't ever act on it. They're stuck in this pattern of I've got to find more information, and at this point it's become maladaptive, and they're not getting anything. It's just a way of it's actually a way of avoiding, but it seems like they're going toward the problem, but it's in an ineffective way. Or again, they might be avoiding the problem, trying not to think about it, distracting themselves with certain behaviors or chemicals, or they might just be immobile, where they're not able to do anything. They're just stuck, and I don't know what to do. I don't know. I haven't done anything, which is in some ways one way of avoiding. And then you want to assess the severity of their behavioral functioning. So in terms of this, you want to think about the effectiveness of their coping behaviors that are being used currently, and the degree to which their general duties and obligations are being met. So if they're somebody who goes to work, goes to school normally, are they able to do that? So are they still functioning? Are they doing what they need to do, or are they not doing what they need to do? And other things to be thinking about are related to what the coping behaviors they're using now. What ones have they used in the past? What maybe have they tried with this particular crisis, and how has it worked or not worked? Right? Again, something that they've tried may be the answer, and they just need more support in doing that thing that's failed. Okay. In the cognitive domain, here, two things. Looking at the timing and the target. So, in terms of the timing, they're thinking about some negative event, the crisis event, and is it something that hasn't happened yet? In which case, it's coded as a threat. Right? Something that's already happened, and it's a loss, or something that's currently happening, and they use transgression to refer to that. And then it can also vary, what is the thing that's being threatened that you've lost, or that's currently being screwed up? And is it something sort of physical resources or needs, being homeless, psychological needs, kind of identity, who am I as a person? There's been some threat to that, or I have a loss of identity. Or maybe it's social relationships, so divorce, or moral, or in the moral spiritual domain, maybe I've experienced a loss of integrity, or a threat to my integrity, which is related to, crosses over with psychological, how I see myself related to my values, or my belief system. And you want to, again, assess the severity. Excuse me. And this is about it's about assessing both their kind of general level of cognitive functioning, so ability to concentrate, to use their kind of higher order executive functioning to organize tasks and to make distinctions and delineations between ideas, right? To impose order on their thoughts. Right? So how well are they able to do that versus being distracted and unable to think clearly? But also we're looking at the presence or absence of intrusive thoughts, typically about the crisis event. So if they have these frequent intrusive thoughts and can't control them, it becomes even obsessional in nature. That's greater severity. And then there's also another component of it is looking at their perception and their interpretation of the crisis. Right? Is it consistent with reality, or is there some distorted thinking going on there? Right? And often that involves the distortion involves blaming themselves for something that's not their fault, or it might be related to control. So something that seems out of control that really they could have control over, or things that they did have control over, they could have prevented, or that they can prevent in the future, that now seems uncontrollable. Right? So, are they thinking about the crisis event in a realistic way, or is there some distortion going on there? Okay, so you can look at these 3 areas, and you can score each one and come up with a general score for their level of functioning, and then think about if it's on the lower impairment, moderate impairment, to the severe impairment. If you get to that severe impairment, now we're thinking, okay, this is typically going to involve some risk of self-harm, and I'm going to need to be more directive. And if I get down to the lower end of impairment, I can probably be less directive, and I'm less concerned about the risk of harm to others. Okay, so that's the triage assessment, system triage assessment form, which seems pretty helpful. So once we've got some initial assessment information related to all those things we've talked about, we can begin to work on the model. Right? So the first step is to define the problem. And it's really important here for this to be from the client's perspective, which again involves an appropriate level of cultural awareness, not to impose what you think is the problem, but to understand from the client's point of view, what is the problem, what is the issue. With a caveat here, I always live with caveats, that you want to respect the client's perspective, but you also need to identify if the client's got some cognitive distortions influencing their perspective, you may have to challenge those. You know? And that's where it gets tricky. Well, okay, is this, should I respect the client's individuality, or is this a reflection of pathology and not thinking clearly, appropriately for any individual? And that's tricky. But as much as possible, define the problem from the client's perspective, and you want a clear and specific definition. So not the problem is everything's horrible. Well, okay, let's make stuff not horrible. No, we need, what are we working on? And there may be multiple problems, and you may have to prioritize. Okay, all these things are relevant problems. We have, one day. We have right now to work together, and then I can refer you to further services. But right now, all we have together is this hour, right? Or maybe we have these 4 meetings. What things do we need to do now? So you may have to prioritize and not be able to address all the problems. And so you may want to help the client identify which thing you would work on would have the broadest impact. Maybe it would help alleviate other issues. Okay. As we've talked about before, you want to ensure client safety, and this is throughout. But whenever you do this, you want to communicate, I think, to the client how important this is to you, that your priority is their safety, and telling them that directly, right? And it does a couple of things. It helps establish a sense of safety for them. Again, that, okay, this person is worried about me and they want me to be safe, and they're going to be looking out for if I might be dangerous to myself. Ooh, that's good, because right now I don't feel like I can trust myself so much. So there's somebody else there looking out for me. And it also helps establish your commitment to them as a person, right? It's not just, okay, your client 43 today, my number one job is to make sure you're well and alive. Right? And I can't do any of the other work that we need to do if you're dead. Right? So I'm committed to life for you. So ensuring client safety, and then providing support, which may involve, I kind of talk about physical needs, supporting their physical needs, which is doing more kind of social work stuff, make sure they have shelter, clothing, all those sort of things. They have electricity, running water, and then also their psychological needs. And this is where you really are applying all those listening skills we talked about before, and establishing that rapport, and helping them explore feelings. And you may be doing some cognitive work here too in supporting them. And you're this whole time you're doing assessment, and you're kind of feeling out what resources they might have, and helping them realize what resources they might have. And so, even though this first part of the model is thought of as kind of the listening phase, and the active phase comes earlier, there's a lot of active stuff that goes on with the providing support and attending to those psychological needs. And the process of talking about their feelings is important and is helpful with clients beyond, or in addition to making plans to do stuff. Okay? But these first three steps in general represent what in our field is often termed psychological first aid. Right? So think about this metaphor for a second, what it means for psychological first aid versus psychological surgery or psychological hospitalization. Right? So first aid is a lot about doing triage, so identifying what problems are there, and then dealing with the problems that will cause immediate harm if not addressed. Right? So if we kind of look at the medical analogy, you do a triage and you notice that, okay, this person has a melanoma. And that's bad. And they also have a severed brachial artery. So the melanoma is serious, right? It kills a lot of people. It's an aggressive cancer. But if you don't get the bleeding stopped from the brachial artery, they won't have a chance to die of cancer, right? So a client may come in with some clearly distorted cognitions about themselves, or have developed a problematic relational pattern, and that's bad. You got to fix that. But if they can't move from the spot they're standing because they're hysterical and overwhelmed by their emotions, you're not going to have a chance to help them with anything else. You've got to deal with that first. So again, you have to prioritize what needs to be done right now. Even if there are other things that are problems, for crisis intervention, you may have to say, okay, well, that's a problem. And I may have to think about it when working with you, but you're going to need a referral for therapy after we deal with the crisis. Right? Because in first aid and crisis intervention, you know that you're probably not fixing the person. Right? You're patching them up enough to have a shot at healing. Right? So there's more healing that's going to happen later. Right now, I've just got to keep you from going off the deep end. Right? I've got to keep more damage from happening, and sometimes this will be the entirety of crisis intervention, is just kind of the psychological first aid. Sometimes that's all you do is patch them up and then pass them along, and that pass them along could be to therapy, it could be to family or church or other resources, some community that can then oversee and help the person heal and get better. Right. Other times you will have enough time and resources to get them a little further down the road, at least pointed in the right direction, and that's where the second half of the model comes in. So we get to the acting, right, phase. So now that you've established a connection with the client by using your listening skills, you've addressed their most immediate needs, right, and kept them safe, and you've gathered some more information about their coping resources. Now it's time to start putting together a plan to help them return to equilibrium. Right? And again, you're still using your listening skills here, even though we call it the acting phase. Okay. So the fourth step of the model, the first part of the second half, is to examine alternatives. Right? And again, how this looks depends on how directive you need to be. But you're going to be thinking about what resources are available. And it's often important to increase the client's awareness of resources, because crisis has a way of blinding us to help that's available. So there may be things that the person could take advantage of, but because of the crisis, They're so focused on how they're feeling or this one event that they can't see the stuff that they normally might know is there. So, and then there are other resources that they may not be aware of and wouldn't be aware of until they got into this crisis. Right. So we want to examine, okay, what other stuff is out there to help you, but they also want to focus a lot on the actions they can take. Right, what the client can do. Sometimes we get into the mode of working on what can be done to or for the client. How can we help you? How can we help you? And this is important, but we've got to be careful not to create unnecessary dependency because of our own needs to be caregivers. Right? So we have to say, okay, not only what can we do for you, what can you do? What can you do for yourself? And keep that autonomy front and center as much as possible. And even related to resources, what can you do to find out more about what's out there? Right? And then making plans. So we've talked about different things. Now, what are you going to do, or what are we going to do, depending on how collaborative or non-directive you're being. And again, I'll say it again, autonomy. As much as possible, the client should be charged with picking the best alternative or alternatives. Because one, it's kind of an ethical thing. Two, as a practical thing, they're more likely to do something that they picked and that they feel that they picked than something that was shoved on them. Right? And then the plan should be realistic, right? So it should be workable and specific. So the plan shouldn't be, okay, I'm going to find somebody to talk to. No, that's a crappy plan. Who are you going to find to talk to? Right? You're talking about a therapist, you're talking about a family member. Exactly what are we talking about? So make it as specific as possible. And then the last step in the model is to obtain commitment to the plan. And again, doing this without, you're not strong-arming them, but you're saying, is this something you can commit to? Yes, absolutely. Great. Yeah, I guess. Okay, what's the problem? So what are the obstacles? Right. So why might this be difficult to do? What could you see getting in the way of doing what we've talked about doing? So you said you're gonna go to your mom's. Why might that not work? Well, if her boyfriend's there, then okay. How could you find out if her boyfriend's going to be there? Right. So you identify obstacles, and then you continue to problem solve around those obstacles until you've got a plan that is specific, realistic, and acceptable to the client. Okay, and again, throughout all this entire model, you're using all those listening skills and all those action skills in some unique combination that fits with you and your personality, and also is appropriate to where this client is at in that moment in time. Okay. All right. So the last thing I need to talk about is your discussion question, which for this week, what I'd like you to do is look at the 6-step model and think about all the skills and everything we've talked about. Which of the steps do you think will be most challenging for you right now, given what you know, what you're able to do? Which of these things, wow, that I can do this, I can do that. That one I would probably struggle with. That's the hard part of the model, is doing that thing. So which step in the model would be most challenging for you right now, and why? So which step is most challenging? Why is it challenging? And making plans here. What can you do to better prepare yourself to make it less challenging? So what's that? Oh, this is the hard step. Here's why, and here's what I need to do to be in a place where I'm more comfortable doing that thing. Okay, that's all for now. Take care.